All right. So for the, again, people who are new to taking this, basically our goal is to create one assessment or exam approximately every 6 months, just sort of to make it an educational experience for you. No studying, no preparation required. To gauge how you're doing in comparison to your peers. This is not reported to essentially, your score is not reported to essentially anyone except the program director, just to know how you're doing. We only start getting concerned if you are a complete outlier compared to your peers, which in this round, everybody did very well. So nothing to be concerned about there, but just to let you know what our aims and goals are for this exam. We ask the same questions of everyone. We expect, first years to be more descriptive, have differential diagnoses, and, as you progress through to actually have a diagnosis and the molecular and the staining, et cetera. So that's kind of my overview. I assume you can all see this. Can you see my PDF here? Okay, so basically the 10 questions are just outlined here. I'm happy to provide this PDF to anyone who wants it. I'll have each of the individual people go through the answers, but here the answers are listed. We had 3 questions that scored more poorly than the rest. So these I thought were a little bit more challenging questions. Other questions, average percent correct was, 40s, 50s, 60s, even 70s. So I thought that these were pretty great scoring types of questions. If you have questions on the individual scores or how I scored it, just let me know. But you were given partial credit if you came up with a correct answer, or if you had the correct diagnosis on your differential, like you were basically given credit for thinking of it, for ordering the right immunostains, things like that. So over time I've been mapping out how our PGY 1s, 2s, 3s, and 4s have been doing. So pretty consistent over time. Median score is about 50%. So great. First year's due in the 20s to 40s, fourth year's due in the 70s to 90s. So everyone seems to be on track over the past few years or few exams. This year, the average PGY 1 score was about 30. The average PGY 2 was in the 40s. PGY 3 and 4 were in the 50s and 60s. And probably, PGY 3s and 4s have similar amounts of surge path months. There's generally a bigger jump, between 1 and 2 and 2 and 3. So again, seems appropriate. Just for your historic comparison, these were scores in the past for PGY 1s, 2s, 3s, and 4s. And again, 1s, 2s, 3s, and 4s. So I think that's all I had for this document. Anybody have any questions so far?
Nope.
Okay, so I have Dr. Antich, Shane, Virnaka, all of whom contributed questions. There's Cami. Alia and I had a few questions, but I think Antich and Virnaka only had like one each. So do either of you want to go first? You want to go?
I can go first. Yeah.
Okay. Do you want me to share my screen, or do you want to share yours?
Let me see. Can I don't see. Oh, let me see. Maybe I can share screen.
Yeah. So yours was, I'm going to follow along here. Yours was question. What? Yeah. Question
22.
Yep. Slide 21, 22, question 7. Yep, exactly.
Okay. Okay. This was a archaeectomy specimen. I forgot details, clinical details. I'm sorry about that.
20-year-old male with undescended testis.
Okay, thank you. As you can see, this is representative sections of the testicle. You can nicely see tunica albuginea. Can you see my cursor?
Yes.
Okay. This is nice tunica albuginea, and then seminiferous tubules tightly packed around here. You can see retatestis. And then on the low power, you're actually noticing some strange nodules. that are darker, and they seem to be well circumscribed, but nevertheless they stand out, and we need to see what they are made of. Now, the obviously differential diagnosis in in a testicle with nodules is obviously germ cell tumors, sex cord stromal tumors, other tumors, metastatic tumors, and so on and so on. Therefore, we need to explore what kind of cells are part of these nodules, and by going down, you can again appreciate that they are well circumscribed. There's lots of this stroma in between and around, but the cell seems to be uniform. Every cell looks the same, and in when you look at the cytologic features, the nuclei is somewhat elongated, and they have pretty um, non-distinct chromatin. It's not malignant chromatin where you see clumps of chromatin. Neither there is prominent uh, there are no prominent nucleoli, and the cytoplasm is somewhat fuzzy and granular, but not specific of like clear cell cytoplasm of seminomas, or there's no necrosis, mitotic activity, or anything like that. Therefore, you are considering something in a maybe in an area of sex core stromal tumors rather than germ cell tumors. Um, Now the question is, if you are thinking about, let's say, sex core stromal tumors, you have to think about: is it Sertoli cell? Is it Leydig cell? Is it any other sex core stromal tumor? And somehow they mostly look like Sertoli cells that you usually see as a supportive cell in a seminiferous tubule. Now, if you look at around, you actually notice that the rest of the seminiferous tubules actually lack any spermatogenesis. This is a testicle that is devoid of spermatogenesis, and then we see these nodules that are, I'm not sure how big they were, but they are very prominent. Um, in this context, now that we know these are Sertoli cells, because morphologically they look like Sertoli cells, but you can prove that by immunohistochemistry because they are positive for inhibin. We now have to decide, is this something benign or is really some kind of tumor? And in this context, something that is circumscribed, found in undescended testicle, we actually think about Sertoli cell nodule, or in a first described in 1904, I think, uh, as a Pick's nodule. This is the benign diagnosis. It used to be called Pick's adenoma or Pick's nodule, and it's a benign lesion that we often find in undescended testicles, or if we see them together with germ cell tumors, they are usually incidental. Now, the only problem that they that you can encounter is encounter if when they're big enough and they can be detected by ultrasound. Once the ultrasound detects those nodules, it's usually considered that they are tumors rather than benign lesions. Therefore, when you're looking at the morphology, they are circumscribed, they're usually small, they can be up to 1 centimeter, but the appearance is not of a mass that is infiltrating, or it's very well circumscribed. And sometimes you can actually see lots of basement membrane in between, and sometimes even calcifications. Anyway, there's really no size that defines Sertoli cell tumor versus Pick's nodule, but it's usually the morphologic appearance of well circumscribed, uniform population of cells that actually leads to diagnosis, and often in the undescended testicles. And actually, their incidence decreases with the age. And this is actually proven in some autopsy studies where they are not seen after, I don't know, 30, 35 years old. You don't see them anymore. And some people even think that they regress. Therefore, the only issue is when the testicle is resected because there is a larger nodule up to 1 centimeter, thinking that this is actually some kind of germ cell tumor. But otherwise, they are benign lesions. And if you stain them with inhibin, every single cell will be actually positive. Um, there's a nice summary of these findings in 2010 paper in American Journal of Surg by Dr. Albright, and you can search that as a Sertoli cell nodule, and it's a nice description how to distinguish these things and what are differential diagnoses. Very rarely you can actually see some germ cells within Sertoli cell nodules. The differential then becomes, is this a gonadoblastoma? But gonadoblastoma is a specific entity that is found only in a specific clinical setting. Therefore, with that, if you have normal male with XY, that's not a diagnosis to start with. If anybody has any questions, I will answer now, but otherwise, this is a Sertoli cell nodule or so-called PIX nodule.
Dr. Antich, what's the clinical setting then for the gonadoblastoma?
It's hermaphrodite something. It has to be some issues with, I forgot exactly. You can Google that and see, but it's specific clinical setting of some kind of
Like sex hormone dysregulation?
Yeah.
Okay, thank you.
I think the most common misconception here was of intratubular germ cell neoplasia.
The problem with intratubular germ cell neoplasia diagnosis is that the cells don't look like germ cells at all. If you have intratubular germ cell neoplasia, you usually see nice big round cells with prominent nucleoli, and they are kind of filling the whole thickness of this spermatogenesis. These obviously don't have this morphology at all. They are not round, they don't have prominent nucleoli, and the entire population of cells, it's the same within the, if you imagine that this is seminiferous tubule, and you can compare this with this one, just to see how the morphology looks different. Therefore, that wasn't even, let's put it mildly, that wasn't really consideration. And if you want to prove that, you can actually do OCT or SAL4 to prove intratubular germ cell neoplasia, but that wouldn't be even considered because all these cells are inhibin positive.
Okay.
Actually, another stain that you can use, it's SOX9. SOX9 would highlight every single nucleus in Sertoli cell.
Okay. Awesome. Thank you. Anyone else? Otherwise, I'm going to ask either Dr. Bennett or Bernacca to go next.
I can go.
Okay. Do you want to share your screen or do you want me to share it from my end?
Would you share it? I don't
Sure.
know. Yeah.
All right. Do you see question 8? What is the diagnosis?
Yeah.
All right. The patient is an 82-year-old female with left breast lesion undergoing lumpectomy. I hope all of you were able to determine that there were 3 available slides. One was the H&E, one was the labeled up here as myosin, and one is P63. So I can drive if you want to discuss.
Okay, that's perfect. Thank you so much. So from the history, you'll see that this is the kind of older woman, elderly woman with a breast mass. And from the low power, you see that there are those uh, kind of expansile nodules of cellular proliferation. In some of the nodules, um, the architecture is really solid, and it takes a while to identify the very delicate fibrovascular cores. In the other area, on the other hand, the fibrovascular cores are more prominent and kind of hyalinized. So I think you can arrive to the differential diagnosis that there is some papillary lesion, especially identifying those thicker fibrovascular cores. Um, then the other two slides show myoepithelial cells that are negative uh, in in all the fibrovascular, in all the lesion, let's put it that way. They are this is myosin, so it will highlight some, little vessels, but it's basically negative in all the lesion, including fibrovascular cores as well as the periphery of the lesion. So the fact that you don't see myoepithelial cells in the fibrovascular cores should alert you that you probably are dealing with the neoplastic papilla, not with the with the papilloma, right? So we are already at neoplasm, papillary neoplasm. Uh, then going back to the H&E morphology, to those cells, and the fact that there is, for the most part, solid growth. So I think I will reveal the diagnosis at this point. So this is a solid papillary carcinoma that usually occurs in elderly women, and is a kind of controversial diagnosis in breast pathology in terms of assessing for invasion, because as in this case, it argues a dogma that the absence of myoepithelial cells equals invasion, equals invasive cancer. So because those tumors, as long as they are of low or intermediate grade, as in this case, you see there's not much cellular promorphism, not many mitosis. As long as they are low or intermediate grade, as long if the nests are nice, round, and circumscribed, even if they lack myoepithelial cells, according to the current WHO classifications, they should be classified as a in situ carcinoma. And yeah, it's just the current thinking about it, because sometimes they form really large masses, and you would get like to T2 or T3 tumor, and basically because the prognosis is relatively good, they rarely metastasize to the lymph nodes or distantly. Basically, they should be regarded and uh, treated as an in situ disease. Another feature of this neoplasm, it does in some cases, but not in all cases, show neuroendocrine differentiation. So salt and pepper chromatin. If you see more cytoplasm in um, cells, your chromogranin and synaptophysin may be positive, and also they may show intra or extracellular mucin production. Yeah, this case was actually signed out regardless of the absence of the myoepithelial cells. It was signed out as no frank invasion identified. Another end of the spectrum of solid papillary carcinoma is when you have like similarly looking cells. However, the nests will be very irregular. I think that the description is like jigsaw puzzle, very rugged, kind of infiltrative. Then you would be more inclined to classify it as an invasive process, but it's very tricky, how much of it is invasive. Is it all invasive, or of only just to measure like a rugged part that is invasive? So we always show those cases, but I think that take-home message is This is indolent neoplasm. It may lack myoepithelial cells, but as long as the nests are circumscribed and no like frankly invasive classified as a in situ disease, because those are ERPR positive, HER2 negative, relatively indolent. And just last thing that you may also see, apart from like rugged edges of solid papillary carcinoma, you may also see more conventional carcinoma associated with it, that will be either like normal IDC, or because of the kind of mucinous differentiation in those tumors, sometimes it's a mucinous carcinoma, and then you will stage this patient with uh, taking into consideration only the span of the frankly invasive carcinoma.
Thank you. I think most people got that this was neoplastic. Most people called it carcinoma, but I think the most common misconceptions were invasive ductal or even invasive lobular.
Yeah, and this is actually like, if you think about like solid proliferation in the breast, maybe this case is not, it's kind of showing its papillary feature and the low power, but if you think about solid like nested proliferation in the breast, lobular carcinoma definitely in situ, it's into differential. There will be also a solid type of DCIS, low to intermediate grade. And I should also mention, because those not only have neuroendocrine features, like, you know, like neuroendocrine nuclei, but they also can have a spindle, kind of spindly type of morphology. And then so with when you see this spindly cells, also your UDH come into differential. And yeah, if you have only like isolated little nodules, definitely UDH is also into differential.
Okay. Awesome. Thank you. Anybody have questions? Otherwise, we can move on to Dr. Bennett.
I can go.
Okay. Do you want me to drive or do you want to drive?
I can drive.
Okay. I will stop sharing, or do you want to control my screen?
I got
You
it
got
all.
You got it.
Is it up?
Yes.
Is it good? Okay.
Yeah.
Okay, so this is a 43-year-old female with a uterine mass, and she underwent hysterectomy. Okay, so low power, you can see this is most likely the surface, but the endometrium has been completely denuded and replaced by this mass. And we only have the superficial portion of the myometrium here. We have this very irregular, somewhat tongue-like growth pattern of invasion, these large bulbous nests. We go on higher power to look at these nests. You can see the cells within them are relatively bland. There's a larger one every now and then, but otherwise they're very non-atypical. There aren't a lot of mitoses, and you do see this little capillary proliferation every now and then. This isn't the best example of the capillary proliferation in this entity. We go to another area, you can see we have a vascular channel here that is infiltrated or invaded by this tumor. So this has this very small round blue cell look, but it's very bland, not mitotically active. So when we see this, we actually think back to the endometrial stroma, and it has a very similar morphologic appearance to endometrial stroma. So this is actually an endometrial stromal sarcoma. Of course, as you know, ESSs can be low grade or high grade. This one definitely is low grade. We don't have atypia. We don't have these very, very small blue cells that you might expect in a high grade YWHAE NUT-M2 fusion high grade ESS. We also don't have any myxoid change, which is what we can see in the high grade ESSs with B core abnormalities, whether it's a fusion or an internal tandem duplication. We can call this a carcinoma because we have lymphovascular invasion. No, sorry, not a carcinoma, a sarcoma, since we have a vascular invasion and this very infiltrative growth pattern. Otherwise, the other thing in the differential is an endometrial stromal nodule, which should not have any infiltration beyond like 3 millimeters from the main mass. And that one can actually mimic a leiomyoma. And both endometrial stromal sarcomas and nodules, the low-grade ESSs at least, about 50% of both of them harbor the JAZF1 SUX12 fusion. Other things that you can see for molecular in endometrial stromal sarcomas and nodules include a PHF1 fusion, which is often seen if there's sex cord-like elements, and then there's some other JAZF1 partners too, but JAZF1 SUX12 is the most common. On IHC, they should be positive for ER, the low-grade ones at least should be positive for ER, PR, and CD10. Desmond might be patchy if the tumor has a very myogenic appearance. Desmond might be more positive, but overall you should see CD10 positive, Desmond negative or patchy compared to leiomyoma or leiomyosarcoma, which should be stronger with Desmond and even Cal-Desmond. Any questions?
Thank you. Very good cases so far. All right. I haven't seen anybody from GI on this call. Is anybody from GI on the call?
I'm here now.
Ah, excellent. Do you want to share your screen, or do you want me to drive it?
You could drive it.
Okay. So I'm gonna let me pull it up real quick. I will start with, should we start with the easy case or the hard case?
I only know the hard case because that's mine.
Okay, let's do that then. So hopefully, can you all see question 9 with the liver?
Yes, we can.
Okay, so 28-year-old female with liver lesions undergoing transplant. In this case, I thought that the gross photographs were lovely. So I don't know why it's still loading. So I put the gross photographs up there for your review, especially considering that they are multifocal lesions. Okay, and
Right.
then here's the slide.
Yeah, that gross is really important. So whenever you're get at the gross bench a liver resection for a mass, you obviously start looking at the mass and it catches your eyes, but you want to always think about the background liver first. Try to remember to do that because the differential diagnosis is completely different in a cirrhotic liver versus a non-cirrhotic liver. Sometimes you're not sure if it's cirrhotic grossly, but usually you can. And this is obviously completely normal liver. So in a cirrhotic liver, mass lesions are HCC and cholangio and rarely anything else. And some things we just don't diagnose in a cirrhotic liver, like FNH and hepatocellular adenoma. So background normal liver, though, you have to think of metastasis first. And the more nodules you have, the more likely it is to be metastatic tumor. So a gross like this, your first, you open up the bucket, you're thinking, what kind of metastatic tumor is this? It's a background of normal liver and there's multiple nodules. This happens to be a primary tumor, as it turns out, but that should be your thought. Now we look at this well-circumscribed nodule, and we intentionally gave you this whole section of a nodule so that you could see the zonation, and the zonation in this is very important. So I'm just going to say the diagnosis, and it's hepatic epithelioid hemangioendothelioma, a very rare tumor. You're only going to ever see a couple in your entire career, but this is such a great example of it that I thought it was worthwhile for you guys to see. So the zonation at low power, and this is a perfect view here. This central area is always very densely scarred with very few tumor cells, and at the periphery you have a more cellular area, and then it infiltrates. Although it looks well circumscribed grossly, it infiltrates the parenchyma kind of insidiously. So imagine a needle biopsy of this. You might only sample that central area and have a very paucicellular look, be hard to make a diagnosis in this area, or you might catch the edge of the lesion, and then you're thinking of some epithelial kind of tumor. It looks like it's forming almost ducts. They're often entrapped normal ducts, which you see there, and telling the tumor cell clusters from the native entrapped ducts can be very tricky. So a tumor like this, you're going to immediately think, well, this looks like an adenocarcinoma. It has cytoplasmic vacuoles, it has clusters of cells, it maybe is forming even gland formation. And then so you're going to do a keratin, and that's the pitfall that I want you guys to remember, is that the CAM and the A1, A3 can be positive in this endothelial cell tumor. So these are essentially, these are primitive endothelial cells. They're fetal endothelial cells. So they have intracellular lumina, and sometimes you'll even see red blood cells in them. They're not epithelial cells, but they, like other endothelial cell tumors, they can be sometimes keratin positive. So any kind of endothelial cell marker that you want to put on this is going to be positive. So ERG or CD34, or any of the endothelial cell markers. So before you diagnosed a cholangiocarcinoma or metastatic adenocarcinoma, look at that. That looks like a signet ring cell, but it's really a single cell with an intracellular vascular channel with a red cell in it. It's quite amazing. You need to have this rare tumor in the back of your mind. One of the nice things, and we haven't actually come across it yet, but sometimes it grows into pre-existing vessels and forms little papillary tufts, like kind of you'd expect in an epithelial tumor. Here at the top, that I think is a vessel that it's growing in. So you'll see that, and then sometimes you can make it out as more vascular kind of tumor. There are two molecular fusions that are present in these, the YAP1 TFE3, which is the most common, and the WWTR1 CAM-TA1 fusion. And those can be picked up by fish. There are immunohistochemical stains for both TFE3 and also CAM-TA1. We have the TFE3 antibody. It's not optimized for this tumor, but you can try it and see if it's positive, and the majority are positive. We don't have the CAM-TA1 antibody in our diagnostic lab, but you can also send for the fusion. These tumors are malignant. They can metastasize to mostly regional lymph nodes, but they are pretty much cured by transplant. There are recurrences that have been described in the literature. You can't really do a resection though, because it's so multifocal. There are even smaller lesions that you wouldn't see grossly. So doing a segmental resection to collect 3 or 4 of these is not making sense. The proper treatment for these when it's diagnosed is a liver transplant, and then the patients do pretty well. Thank you.
Thank you. Excellent case. 2 questions. Did you do the rearrangements in this particular tumor? And secondly, I know that there's potentially some controversy as to whether these are kind of intrahepatic spread of one nodule, right, or multiple separately occurring things. Do you have any thoughts on either of those?
Yeah, we did not do the fusion analysis in this case because it's really not necessary. It's just more for academic interest. It doesn't guide any patient management. Mm-hmm. And I do think it's probably just a single tumor that's spreading through the liver rather than being separate. I will say parenthetically, a very interesting thing that happened to several years ago. We see one of these every couple of years. We had the son of a very famous microbiologist or virologist over at Loyola or somewhere, one of the institutions in town, whose son had this, and he felt that this was clearly a of bacterial origin, like some other kind of vascular bacterial, like Bartonella, and these causing vascular lesions. So he thought that there was a bacteria or perhaps a virus, but he favored bacteria. And so he put his son on a year-long intensive antibiotic regimen to try to cure this before transplant. But patient underwent transplant, and then we harvested some of the nodules for him to try to isolate bacterial DNA from. It's crazy.
Wow.
Yeah.
Awesome. Thanks. So
Yep.
anybody who ordered a vascular marker got the question right. There were only a few people, so good for you guys who did that.
Yeah, this was the hard one for the exam.
Oh yeah.
I have,
Mhm.
I actually, when I was in MD Anderson, we reported the case of epithelial hemangioendothelioma in the mediastinum that was metastatic to the lymph node and also to the pleural fluid. It was actually mistaken for carcinoma on first round because the patient already had diagnosis of RCC papillary. But yeah, I remember the issue because the keratin was positive, and yeah, you have to be careful with keratin.
Yeah, and I kind of feel like the ones in the liver are a little bit separate from the ones in the bone and soft tissues and other sites. They have their own kind of look that when I show mine to Dr. Krause, or Dr. Krause shows his to me, it's they're different. These are kind of distinctive, and particularly the CAM TA1 variety, which I don't think this is. It has kind of a glassy appearance that's different than bone and soft tissue. Anyhow, it's the same fusions, and but it just looks a little different in the liver as opposed to the lung or somewhere else.
I remember one from Dr. Lingen. He showed me one. I don't know, Nicole, if you remember, from gingiva. We had it like about a year ago.
Okay.
I wonder what happened to that one because that's
Yeah.
an unusual site.
Yeah, I don't know.
Is
Cool.
there another GI case?
The Lindsay Alpert one?
Oh yeah, she's in recovery from her labor and delivery, so we could just call her and FaceTime her in.
Yeah, or you can just go over it. Just
Okay.
so 49-year-old lady.
Now Dr. Setya is here, so
Oh, perfect.
Yes. Looks like some endoscopic biopsies. I don't know anything about this case.
Yes, this was probably on Converse the best scoring case of the bunch. 49-year-old female with chronic diarrhea, congested mucosa, left colon biopsy, and so here's what we got.
So again, we just would look at low power first and say that the architecture looks normal, which goes along with the minimal findings on the endoscopy. Oh, what a beautiful case. Okay, yeah. I'll let Dr. Setya take over since she has a seminal paper on this condition that is referred to. So take it away.
Well, I guess the history of chronic diarrhea is important and normal architecture. And since it's the best scoring, so my guess is most residents figured out that this was either microscopic colitis or variant of it. And since the subepithelial collagen looks very thickened, collagenous colitis comes to mind. Of course, you have to look for other features as well, which is surface epithelial damage and intraepithelial lymphocytosis, which doesn't seem very prominent in this case. And since it's not so prominent, you'd always think of amyloid as well. So I'm not sure, whether, and you could do a Congo-red stain or trichrome to make that differential. Did Lindsay provide that? Yep. And something to remember is that sometimes amyloid can stain with trichrome, so you should do a Congo-red stain anyhow.
So there was a trichrome scanned, but not a Congo red, so I can show the this was not provided at the time of the exam.
Oh,
The
okay.
H&E, and most people got it just based on the H&E.
Yeah.
But I'm showing the trichrome now for confirmation.
Yeah. And it does look thickened in these areas. And importantly, like the collagen will entrap the capillaries, and they're actually called trapellaries, like over here.
That's awesome.
So it's a very nice case of collagenous colitis.
Awesome. Thank you.
Sure thing. And although on endoscopy, they did see some findings though, right? Like minimal.
It was congested.
Oh, okay, good. So it's called microscopic colitis because there are no findings on endoscopy. But you know, that was like old literature, and now it's been reported that you can see minimal findings on endoscopy. So this fits perfectly with collagenous colitis.
Awesome.
One thing I'd like to add, I do a lot of trichromes and Congo reds and heart biopsies to differentiate from amyloid and fibrosis. And it is true that trichrome will stain amyloid, but it is a different color. It's purple, as opposed to this blue, which is trichrome. And I've tried to show that, I think, on this also, that you can differentiate amyloid and fibrosis based on just the trichrome.
So what component of the trichrome is
Instead of this blue, the amyloid will be a purple. Everything else stains the same way, obviously. Just the amyloid will stain.
Like maybe, yeah.
Yeah.
This is the component that's picking up the collagen, right?
This is just the collagen, right? So
Okay.
the control is just fibrous tissue. But I'll show you when I next have one. I'll show you a trichrome on the amyloid.
Okay. All right. Awesome. Anybody questions? Otherwise, Dr. Hussain, you can do your two cases.
Okay. Could you show it, please?
Yep. This was a 67-year-old male with hypoxia and diffuse lung infiltrates. What is the histologic diagnosis, and what are two clinical settings in which this occurs? So you got both an H&E and EMS.
Okay. And how did they do?
I lost it. Hold on one second. They did. Most people got some kind of bug. So if they got at least some kind of bug, I gave them partial credit.
Yes.
But some people got an incorrect type of bug.
Okay. All right. So just looking at it, so when you first look at a lung biopsy, you will notice that overall there's not much inflammation. The architecture is pretty well preserved. And so upper right, there's a very normal looking piece here. And then there are others that look busier. So maybe we can go there first. Right. So if you look in here, then you start saying, well, what is making it busy? So part of it may be because the lung looks like there's just too much lung, maybe collapsed. And then as you go higher power, you'll notice that there are some macrophages in here or some cells. And exactly right here. So Nicole, this is a great area. So when you look in here, it looks like there are little blue dots inside. And so you have to look very, very carefully and see, well, what are these cells and what are these dots? Because the two things that will come in your differential would be pneumocystis and disseminated histoplasmosis, which looks like this. And the way to differentiate those is there's those little blue dots in PCP or pneumocystis are actually just intra-alveolar exudates. Whereas here, it almost looks like that these are within cells, although this particular focus, you can't be 100% sure. But if you look around, there are other areas where you can clearly see that this seems to be in, right, let's go down here. Although some places, like here, you can't tell at all. It almost looks like these are but they're not the frothy intraalveolar exudates. There's a little something different about it. It is more proteinaceous and a little more pink. So, but that should be, if you thought about it and ordered the right stains, that would be great. So then I would look at the GMS. And here what you will notice is that there are clusters of organisms. So once you have these sort of cystic things that are GMS positive, you are in the group of fungus, because bacteria would be much smaller. Then how to decide between pneumocystis and histoplasmosis is your main issue as to what is going on here. So looking at this, if you see how there are those little cysts with a dot in the middle, like those, this really is pneumocystis, which is why you were seeing those sort of areas where you can't tell whether this is exudate in the alveolar space or intracellular, because disseminated histoplasmosis is all intracellular. They don't proliferate freely in the space, whereas pneumocystis does. You'll see collapsed forms here, and they're pretty much very uniform in size, whereas histo can vary more. And also then you need to look for, are they really truly budding or not? That will help you. And then if they are any one that you can find that's pointed at one end and rounded at the other, that would be histo. So the features of histo would be pointed, pear-shaped, true budding, and in immunocompromised hosts, they are all intracellular. And you will, in neither will you have much inflammation, which is what you see in this patient. And the features of pneumocystis that are present here are, some are collapsed and helmet shaped. They are lying in the air spaces as well. And then the clusters, they're all very uniform in size, and they're about the size of an RBC. Any questions? You really need to know pneumocystis, even though we are seeing it less now with better treatment and prophylaxis. You like, oh, here. So this is a classic frothy exudate in an alveolar space. In this focus, you don't have any doubt that this is a space and not intracellular, because other areas we could not be so sure, but this is really a very good section. And so one of the things is, oh yes, as Tatiana says, they can be easily seen on BAL specimens also. You do need to call it based on H&E, especially on a Friday or a long weekend if you get to see it, because this is easily treatable and you don't want to wait too long. And I'm not sure if we called it, hopefully we called it based on the H&E. And the other thing is we don't see them biopsy for pneumocystis anymore because the BAL really is very diagnostic.
Cool, thank you. So, and obviously immunocompromised state, AIDS-defining illness type of.
Right. But sometimes you don't have that history. This may be the first presentation. I think like this patient, I don't think they knew that he had AIDS. Or she, I forget.
Right.
In that age group, you really would not be thinking HIV in a new diagnosis of HIV in a 67-year-old. Okay, good. And then the two clinical settings would be either acquired immune deficiency in this age group and immunocompromised, and malnourishment in pediatric age group. So this actually, I don't know if you remember, but PCP was first identified, I believe, during the Second World War. Second World War, when there was so much malnourishment that the kids were getting, they were so poor that they were getting PCP.
Wow.
In little kids in Africa. I think is where it was first described.
Okay, and then your next case was a 43-year-old male with mediastinal mass. Here's an overview of the gross. I didn't have a cut image. So what is the diagnosis and subtype?
Okay, so one thing then that image does emphasize is for the residents, please, when you are taking pictures for anything, including lung and masses, just taking a picture of the outside is not enough. Once you cut into it, you do need to take a picture of the cut surface. It's actually also, I mean, both are equally informative and you can't do only one. Okay, so on the cut section here, the first thing at low power, at this power that you will notice is that is a key feature of this tumor, is the lobulated nature. There are very few things in the mediastinum or the lung that are this lobulated, that there are septa going through it, which divide it up. This is very, very characteristic. So you should start thinking thymic tumors already because of it. So now, and the history is typical, right? Anterior mediastinal mass. So then you're thinking thymus. In an adult, other things that you should keep in the back of your mind, obviously, is could it be a lymphoma? because that can occur both in the anterior and the posterior mediastinum, or could it be an extension of a lung tumor, which you can present as a mediastinal mass, because if it was very close to the hilum or anterior, it can, most of the growth can be in the mediastinum, and that's how they call it, and then you don't know exactly where it's coming from. So you do have to keep a differential in mind. And then when you go closer, you notice that the cells are made up of there are two cell populations. One is larger and one is a smaller. So the smaller are the normal thymic lymphocytes that are present in a vast majority of thymic tumors. And right, those that Nicole is pointing out so nicely. And then there's the larger cell, actually there are three cell populations. We'll come to the third one, which is the starry sky, macrophages. And then there is this intermediate sized cell sheets of cells, which do have prominent nucleoli, and they have very little cytoplasm. So based on this, you would be thinking that this is a thymoma. You've excluded thymic carcinoma because it doesn't really look malignant. For thymic carcinoma, the first thing should be it should look malignant. It should have mitotic figures, have atypia. It's usually not bland or low grade. Oh, so this one does have two distinct areas. So there is this area where it is mostly spindled and kind of haphazardly. And then, so in a thymoma, this would be a type, WHO type A, because it is spindled and it has sparse lymphocytes throughout. That's a very classic picture of a type A. Whereas where we were before is a type B, because a B is a mixture of round thymocytes and lymphoid cells. So the neoplastic component are the epithelial thymocytes. If you were to do a keratin stain, all of those intermediate sized cells would stain positive. They would also be P40 positive because these really are squamous lineage, both P63 and P40 positive, and they will mark with all the keratins that you expect in a squamous cell. Another way to differentiate, if you really have a small biopsy and you want to differentiate from, say, a lung cancer, that of course TTF1 would help. But if it was a P40 positive and you were going to try and differentiate from a well-differentiated squamous cell carcinoma, another thing that would help would be typing the reactive lymphocytes, because remember, these lymphocytes are of thymic origin. So they are CD5 positive, the lymphocytes. Whereas in a lung squamous cell carcinoma, if they are reactive lymphocytes, they are not CD5 positive. Okay. The last teaching point is if you had to differentiate from a thymic carcinoma, the majority of the thymic carcinomas are CD5. The epithelial cells become CD5 positive, whereas in a thymoma, they are not. So the epithelial cells in thymomas, CD5 negative, P40 positive. Whereas in a thymic carcinoma, the malignant cells are both P40 positive and CD5 positive, and they may also be CD117 positive. Any questions? So this is a WHO type AB. Once you say AB, you don't have to further subtype B, but in a comment, sometimes I do, because this would be a B2, because it has an intermixed. Actually, you really don't need to subtype it. So you could or you cannot.
Is there a clinical or prognostic difference between the types?
Yes. So in the A, pure A is the best prognosis. It's the most benign, in the more benign, and all of them are low-grade malignant. All of them are malignant thymomas. If it's encapsulated and completely resected, type A has the best prognosis. Next comes B1. B1 also is lymphocyte predominant. So in very few thymocytes, that also, if it is removed completely and it is not invading through the capsule, has a very good prognosis. B2 is intermediate and B3 is a little bit more high grade. However, we've seen, if they're not resected in time, since this is a slow growing tumors, we have seen metastases of even B1, and I've seen metastases of A also. You can have dropped down metastases within the pleura. And the last one that we had was I don't remember if it was a B1 or a B2 that had metastasized to the liver. So it can go outside the chest also.
Okay, thank you.
And they're very difficult to treat because they're so slow growing. Surgical resection is really the only thing they can do.
Great, thank you. Anybody questions?
There is something in the chat. Let's see.
All right.
That's for the last case. Okay.
Right. All right, I'll do my last two. So we'll start with the thyroid. So this is a 25-year-old female undergoing lobectomy for thyroid nodule. And most of you got 2 of the 3 diagnoses, which were some kind of benign nodular lesion and some kind of background thyroiditis. The hiding diagnosis, which only a few of you got, was a microcarcinoma. So I will go over it. So, you know, on low power, what stands out is there's a vague nodule, right? There's a vague nodule that kind of stands out from the background. And so I would consider that to be of, you know, of diagnostic import, especially given the fact that clinically she has a nodule, right? So sometimes we think, oh, is this nodular hyperplasia in the background? Is this a dominant nodule? Sometimes we go by the clinical and say they saw a nodule, so let's confirm it and address it. So we see this vague nodule standing out from the background. Let's first just look at the background. I mean, most of you pretty clearly identified that this was some kind of chronic lymphocytic thyroiditis. There's lots of lymphoid follicles with occasional germinal centers, and the epithelium in the background looks somewhat plump. The nuclei are enlarged, but it's all sort of uniformly enlarged. And so we accept some nuclear enlargement and atypia in the setting of chronic thyroiditis. Especially with this much, you know, diffuse inflammation. Okay, so that's one thing. Maybe she has Hashimoto's. Again, I sort of leave that to the antibody to determine whether something is Hashimoto's or not, but this is at least pretty florid chronic lymphocytic thyroiditis. Okay, then this nodule. The nodule itself also has some inflammation incorporated within it. But when you look at the actual lesional cells, they're relatively round. On occasion, you see an elongated one. But in general, you know, I don't find that this is composed of papillae. It's all follicles. I don't find really any nuclear clearing or pseudo-inclusions. The chromatin is still very dark and stippled, even if the nuclei are occasionally enlarged. But again, there's some inflammation, so I'm going to allow for a little bit of nuclear enlargement because of the inflammation. So otherwise, I think most of you got that this was a benign adenomatous nodule in the background of chronic thyroiditis. Again, if you have questions, please holler them out. But the one thing that, you know, you always have to keep looking, right? Keep looking until you find something worse. And so, you know, just because you have 2 diagnoses doesn't mean that there's not another one. And maybe you can see on intermediate power that there's an area that sticks out a little bit. It looks kind of glassy and maybe a little more kind of amphiphilic purple compared to the very blue lymphoid background. And so it was this one area right here where, oh, there, perfect. Well, we'll land on that first. But if you don't land on that pseudo-inclusion, at least land on the fact that there is some shift. There's some shift in the quality of the cytoplasm. It becomes a little more dense and eosinophilic. There's a shift in the nuclei. Compared to the background, they become even more enlarged, even more clear in the chromatin. And then you finally see a definitive intranuclear cytoplasmic pseudo-inclusion. And you can, if you compare, you know, this nest and this nest and this nest to that nest and that nest and that nest, I think you can see the shift, right? And so a lot of times it is comparing things to the background. There's a beautiful neoplastic follicle right there with very clear nuclei. So yeah, so this was a papillary microcarcinoma. Again, not going to change the clinical management or prognosis for this patient, but we do report these when we see them. So questions or comments on that? So congrats to the few of you who found the microcarcinoma. And then, oh, Dr. Hussein actually has a third one, but let me do my second one and then she could do her third one. All right, so this is a 69-year-old male with a neck mass undergoing excision. What is your differential and what ancillary studies would help? So hopefully you were able to identify that there is a lymph node here. You see pretty much normal lymph node architecture in the background with germinal centers, with a capsule, with a sinus. Okay, and then maybe here's the hilum in the center. And there's some effacement or involvement of the lower portion of this node by these epithelioid to spindle kind of very plump cells. And the thing that I would like to sort of, emphasize, and what I know that those of you who've been through heme hear this as well, is that these patients present with, unilateral, solitary enlarged lymph nodes, and the differential diagnosis is some kind of MET or some kind of lymphoma. And so these also often get seen by heme, okay? But what we can tell is that there's a shift in the population that is no longer a lymphoid cell, but more of a very plump epithelioid cell that in this case doesn't have very well-defined cell borders. And you know that one of the things I always teach you is if it's metastatic carcinoma in a lymph node, always look for cell borders that can help you. This is one of the exceptions, okay, where you see just overlapping sheets or buzzword syncytia of cells, right, that have large nuclei with open chromatin, with mitoses. If you look around, there's one, there's another, and there are lymphocytes and plasma cells percolating amongst these syncytial epithelioid cells. And so if you haven't burned this syncytial pattern into your brain of plump epithelioid to spindle cells with lots of mitoses, with percolating lymphocytes in the background, this is classic characteristic for not only carcinoma, but particularly nasopharyngeal carcinoma, okay? Yes, there's some little central necrotic islands here. So some of you ordered squamous markers. That would be great, because in a middle-aged man with a epithelioid thing and a neck mass, you're thinking about squame. You're maybe thinking about HPV-associated squame in that age group, which is a great consideration. So here's a P63, P40 confirming squamous origin. But that syncytial growth pattern is actually very, very, very characteristic of nasopharyngeal carcinomas, which are not usually HPV driven like the oropharyngeal ones, but they are EBV driven. And so this is an EBER in situ hybridization showing you just strong positivity in those squamous islands and essentially negativity in the background lymphocytes, okay? And so those of you who call this a carcinoma, great. If you called it squamous, even better. If you called it, or you asked for an EBER, perfect. So we know that, in this age group, HPV cancers are more common, but EBV cancers can certainly occur, and it's this classic morphology that should guide you. If you do the P16 and it's negative, so just FYI, this was a consult from an outside hospital. They did the P16 and it was negative and they stopped there. Don't stop there, do the EBER. And vice versa. If you see something like this and the EBER is negative, do the P16, right? So think about it as a stepwise process. Questions, comments? Okay, and I know if you've done the heme exam, you've had one of these on your exam in heme. Oops, I shouldn't say that for the people who haven't done heme. Okay, Dr. Hussain, do you want me to do your last case or do you want to do it?
Oh, you do it. That's fine.
Okay.
It's equally.
Equally, we'll do it together. All right, so combined effort. So last case, a 64-year-old female with a pleural mass undergoing excision. What is your differential?
That's a beautiful photograph, whoever took it. Well done.
So to your point, the outer surface and the cut surface were photographed and they were both helpful, right? So here's the outer surface showing a glistening capsule, right? So you know that this is sort of probably protruding into some kind of lumen like the pleural cavity, right? It's lined by this glistening surface. And the cut surface is this very white, almost you could maybe think about something like leiomyomatous, but it's not quite as perfect. But it is this very, very white and yellowish cut surface. So nice job on those. And here's the image. So for context, we can look around and we can see actual background lung, right? So there's a nice kind of respiratory epithelium. And this thing is kind of stuck on next to the lung parenchyma. And so on higher power, what is striking to me is all this background eosinophilic kind of ropey looking collagen intermixed with these relatively bland, occasionally compressed spindle cells with oval nuclei and kind of fine chromatin. Dr. Hussain, what do you want to add?
So it is true that it is coming off of the visceral pleura. So we think of these tumors as being really pleural based. It can invade the lung. So you do have to look into it and you have to report that if it invades the lung or not. So here at the interface, you want to see is the tumor going into the lung or not. And here it clearly is. So you can see that there are spindle cells growing on both sides of the respiratory epithelium. You never see respiratory type epithelium in the pleura. So if you can be sure that this is not reactive mesothelium, which is the other thing, this could still be reactive mesothelium. But if you can find cilia anywhere, on this one, I really can't tell, but other areas, I think it was invading into the lung.
Okay, cool. So either pleural based plus or minus lung infiltration are things to look for. Okay, so with that being said, the nuclear morphology of these tumors is, again, very bland, very oval, very sort of blunt, not very wavy. And I would argue that in your differential diagnosis of spindle cell lesions, when you see something with wavy nuclei, you might think of something Schwannian or nerve sheath. When you think of something oval or cigar shaped with eosinophilic cytoplasm, you'll think of something myeloid. But when you have something like this, that's kind of oval or cigar shaped or minimally pointy, but without cytoplasm, these nuclei come right in contact with the stroma. Think about something fibroblastic, myofibroblastic. And those of you who were at Aaron Udiger's talk not too long ago probably remember having seen this tumor in his talk as well. So this is a solitary fibrous tumor and of fibroblast, myofibroblast lineage. And so the stain that I'm showing you here, which I do not think was provided on the exam, I think only the H&E was provided on the exam. So anybody know what the cytoplasmic marker for SFTs is?
Stat 6.
Okay, I asked what is the cytoplasmic marker?
Oh, I'm sorry.
No, it's okay. What is your marker? What is stat 6?
Well, I guess it would be a nuclear marker.
right, because it's a transcription factor, exactly. So stat 6 would be your very highly specific nuclear marker for solitary fibrous tumor, and your other specific but less so cytoplasmic marker is, let's see if we can get us a clue. It's also staining the endothelium, so it's CD34. So between these two stains, oh yeah, there, look, there's a vessel, right? So there's the endothelium staining with CD34, and here's all the tumor cells in the background. So yes, CD34 cytoplasmic and STAT6 nuclear. I think it's just, it's important to know what compartment you're looking for expression in, because sometimes STAT6 could have aberrant cytoplasmic expression that is not nuclear, which is irrelevant, okay? So just remembering that compartmental difference. So that was an SFT.
So you also have to decide, is it benign or malignant, or at least just SFT or a malignant SFT, or you don't do that?
So I am of the personal belief that no SFT should ever be 100% considered benign, because it's a spectrum, and there are features like size, right, like cellularity, like mitoses, like necrosis, that push it farther along the malignant side. But we know, at least in a lot of the studies of the lung, pleura is the prototypical location for SFT, even though you can see these in the brain, right, formerly HPC, in the soft tissue SFT, but the prototype is the pleura. And studies, right, as I'm sure have shown that you can't always predict behavior based on histology, but you can sort of give it a spectrum of benign and malignant. But yes, I don't know, what do you do?
I do. I tell them whether it's likely to be, low grade or intermediate grade or unknown,
right,
or something like that.
Right.
So
no,
I make a comment, right, for them.
Right. I think you report those features. Thank you. Report all of the importance of those features and say it's on the lower end or the higher end.
Yeah. Right. And I usually try and give a reference for that.
Right.
They see they are infrequent, even though it is the prototype. The resection of an SFT is really infrequent. I think I see maybe one a year, maybe less.
Yeah, I think we see them in the soft tissue and even in the sinus.
So you see more of them than I do.
All right, I think we've gone through everything. So thanks, everyone. I hope this was educational. If you want to know, some of you have already asked to know your individual scores, which I'm happy to send. If you want, just email me.